Yes. So thyroid malignancies, when we talk of, we all know, we have gone through the basics of the thyroid modules. We know the histology now. So it is the basic structure of thyroid. It is follicular structure. And inside each follicle, there is colloid, which is filled here inside the follicle. The follicle is surrounded by the follicular epithelium. This is the follicles or the follicular cells, which are the principal cells. And along with the follicular cells, we also know, as per the histology, that there are certain parafollicular cells. So basically, the gland has two types of cells, the follicular cells, the parafollicular cells, and the follicular cells form the colloid in the follicle, and inside the follicle is filled the colloid. So this is the basic histology. So what are the options of malignancy? Malignancies or the cancers can arise from either of the two cells. So there are two types of active cells, the follicular and the parafollicular. The tumor might arise from any of these cells. And then there is another option that the malignancy can arise from extrathyroidal cells. Like there can be a lymphoma, and also there can be sometimes metastasis, that is cancers arising from outside somewhere in the body can reach the thyroid. So how do we classify the thyroid malignancies? Either it is follicular in origin. So when it is follicular in origin, it can be papillary carcinoma. It can be follicular adenoma or carcinoma. It can be anaplastic, or it can be poorly differentiated. So this is basically the primary thyroid carcinomas arising from the follicular cells. Then we have some follicular variants like the Hurthal cell adenomas or the Hurthal cell carcinomas. Then the parafollicular cells or the C cells in origin, they can have parafollicular cells giving rise to medullary thyroid carcinoma, which we commonly know as MTC, that is medullary thyroid carcinomas. Then of course the extrathyroidal cells, we can have sarcomas, lymphomas, and very rarely we can also have metastasis. So the mets can come mainly from, it can be a direct extension from the neighboring organs, or most commonly they are seen from kidneys. And then also coming from colon or melanoma. So this is about the thyroid malignancies. Thyroid malignancies, if we look at the frequency or the most common variant types or the most commonly coming across, so it is the papillary carcinoma, which is most common in occurrence, the incidence prevalence. So we find 75% of the thyroid malignancies to be of the papillary carcinoma variety. Then next common is the follicular carcinoma, which is 16%. Medullary carcinoma is lesser in amount, that is only 5% of the cases are MTCs. Undifferentiated 3%, and all these miscellaneous put together constitute some 1% of the burden. Now the epidemiology wise, the most common endocrine malignancy is thyroid malignancy. They contribute 1% of the total body malignancies. If you look at the incidence wise, they will around 4 per 1 lakh of the population. Again, the bias is towards women. So women is more commonly affected. Age group wise, it can affect any age group, but most commonly it is the young age group between 30 to 50 that we find this disease most commonly. If older population is affected, then the disease is more aggressive. Otherwise, thyroid malignancies are safer malignancies with good prognosis. So 5-year survival rate is almost 97%. The only exception being the anaplastic thyroid carcinomas, which have a lower survival rate. If you look at the reason that why do we have thyroid malignancies, so in case of MTC, it is most commonly the RET oncogene. So it is MTC is most commonly associated with syndromes. So we come across the MEN2A and the MEN2B. That is the most common malignancy associated with medullary thyroid carcinomas. So we have the Sippel syndrome, where we have the Marfanoid features, and also we have the MEN2A. So it is the thyroids, parathyroids, and the FAO. Then the family history. Again, in the family history, the history of goiters, increased risk of papillary carcinoma. Papillary malignancy, the papillary carcinoma thyroid is the papillary thyroid carcinoma, PTC. It is the most preponderant, most common carcinoma seen in thyroid malignancies. Then association with other polyps like the Gardner syndrome or a familial adenosis polyposis, they all increase the risk of papillary thyroid carcinomas. Radiation exposures, if the patient has been exposed to radiations of head and neck because of some other reasons, some other cancers, they are likely to have a sequelae or a follow-up with thyroid malignancies. Exposure to radioactive iodine during childhood, for example, the Chernobyl incidents or other radioactive substances, they increase the risk of papillary carcinomas. But these are all very rare episodes. Most commonly, we don't have any reason, but patients come to us with thyroid malignancies. And they basically come to us with thyroid nodule. And it is a workup of the nodule which tell us that the patient is having thyroid carcinoma. Other reasons being iodine deficiencies, which increase the risk of follicular carcinoma. So now this is interesting. Chronic iodine deficiency will lead to follicular hyperplasia or enlargement leading to follicular adenomas. And these follicular adenomas are at times converted into progress into follicular carcinomas. Gender-wise, again, the preponderance is more towards women. More common young age. MTCs are usually diagnosed after 60. White race is more affected than the black race. Now coming to the oncogenes and the tumor suppressor genes which are involved in thyroid tumorigenesis, the list may be long, but we are only concerned with the RET oncogene because that is responsible for the MEN2A syndrome. So the RET oncogene, the MET oncogene, TRK1, TSHR, GS-alpha, RAS, the PAX8, PPR, gamma-1, these are all the oncogenes which are linked to thyroid malignancies, especially the RET is associated with MTC, and MET and TRK1 are associated with papillary thyroid carcinomas. Similarly, we have the tumor suppressor genes. So loss of these genes can lead to malignancies like the P53, P16, and the P10. Now, how do we approach? What happens? Suppose the patient is coming to you, this we studied previously also in the case of thyroid nodules class, but we are just revising it. Suppose there is a thyroid nodule. So what do? If it is a benign or a malignant, you'll come to know only by FNACs. So if it's FNAC again, we'll see that it is not 100%. But suppose you come to know that it is a malignant issue or a benign issue. If it is benign, it has to be a follicular adenoma or a papillary adenoma. Just leave it. You don't need to do anything if it is a euthyroid, if the patient is euthyroid. But if it is malignant, then you think of it is whether it is a primary malignancy or a secondary malignancy. Secondary malignancy will give you the source of primary somewhere, maybe a kidney, maybe a colon. But if it is primary, then you think whether it is a follicular type or it is a parafollicular type or a lymphoid type. Lymphoid is always a lymphoma. Parafollicular will be medullary thyroid carcinomas. If it is follicular type, it has to be either differentiated or undifferentiated. Undifferentiated means it is anaplastic, which is very severe and the mortality is high. If it is differentiated, it will be either follicular variant, papillary variant, or a Hurthal cell variant. So this is just a repetition of the same table that we started, that how does we classify the thyroid malignancies. Now the clinical presentation. Patient will not come to you with malignancy. Patient will come to you either with a solitary thyroid nodule. So most common presentation is a single solitary thyroid nodule, and on workup, you will inform the patient that this nodule is malignant. But most of the time in thyroid nodules, 99%, they are all benign. Then there is hoarseness of voice. A persistent hoarseness of voice is another pointer towards malignant nodules. There can be enlargement of the cervical lymph nodes. There can be difficulty in swallowing, difficulty in breathing. There will be some pain and persistent cough. So these are the clinical presentations. How will the patient come to you? And then how will you work up and reach the final diagnosis that the patient had thyroid malignancy? So on your workup, first of all, whenever a patient is coming to you with any complaint of thyroid, definitely the thyroid profile becomes the primary investigation. So we have TSH and T3, T4. Then we have the serum thyroglobulin. The significance of serum thyroglobulin is not to differentiate between malignant and benign. The significance is only in follow-up. Then the antibodies will again tell us the autoimmune nature of the disease, and more important to find out the Hashimoto's or the Graves. Sorry. Then FNAC, it is not going to differentiate between follicular variant, but FNAC will tell you if it is malignant. And if it is benign and it is follicular variant, you need to go for a true cut biopsy. We even require intra-op frozen sections. You can go for imaging modalities, ultrasonography, CT scan neck or MRI neck, or a scintigraphy. That is radionuclide imaging. So most of the patients come out to be euthyroid. If it is a hyperfunctioning nodule, then the chances of malignancy decrease further. Most common, it is just 1% of the total hyperfunctioning nodules which are ever malignant. Serum thyroglobulin cannot differentiate between malignant and benign. It is only used for the follow-up. That is, after total thyroidectomy, you have to keep it under follow-up. If it is rising, then you are alert that again the thyroid follicle is regenerating. So serial follow-up is required for the non-operative treatments also. Then the serum calcitonin, this value is done for the MTC, that is medullary thyroid carcinoma. And the value has to be significantly high, more than 300 maybe at times, to confirm your diagnosis of MTC. FNAC, that is cytology. This was popularized in 1960. It is most important test. FNAC coupled with ultrasound. So it is a USG guided FNAC because at times the nodules are quite deep seated and they are quite small. So the accuracy range of FNAC is 90%, almost 70 to 90%. In most of the cases, those nodules are benign. Very rarely you come across some malignant nodules. At times they are suspicious or intermediate, and then you suggest a frozen section is taken. And at times the answer is that the sample was insufficient. But still the FNAC cannot differentiate between the benign and the malignant nature of the follicular neoplasia. That is important to remember. Imaging studies or the imaging modalities. Ultrasound is the investigation of choice. You can go for ultrasound guided FNACs also. Ultrasound will tell you whether the nodule is solid or cystic. If it is cystic, you can aspirate it. If it refills, again aspirate it. So if after 3 aspirations, you have failed 3 aspirations, then you go for a surgery. Ultrasound will also give you the size. So if it is more than 4 centimeter, then go for a surgery. It will also tell you the content, whether it is calcified. So if there is microcalcification scattered, go for surgery. If there is adjacent lymphadenopathy, that will be clear in ultrasound. And that is again a pointer towards malignancy and a radical neck dissection. I mean, surgery, of course. Then CT. CT will again tell you the regional and the distant metastasis. MRI will have a limited role in the diagnosis, but for the distant lymph node metastasis, you can choose MRI. Scintigraphy, that is iodine studies or the gallium studies, they will characterize a functioning nodule. So if it is a hot nodule, then it is thyrotoxic nodule. You don't need to think about malignancy. Most commonly, it is very rare. If it is a cold nodule, yes, there becomes it's become important. Then this cold nodule needs to be verified with your US guided FNAC. Staging of the cancers can be done using the scintigraphy. Gallium-67 is used for the detection of lymphomas. Reaching back to the same picture, solitary nodule, go for FNAC. Non-diagnostic, repeat FNAC. If it is benign, if it is cystic, aspirate. If you aspirate and your aspiration fails 3 times, go for surgery. Colloid nodule, just observe, don't do anything. You might start a thyroxine, but still if it is growing or if there are compressive features or there are pressure symptoms, then you need to go for a surgery. If this FNAC is giving a suspicious nodule, go for a radioiodine scan. If the radioiodine scan is giving you a hot nodule, ablate it. If it is cold nodule, go for a surgery. If your FNAC is giving you a clear picture of malignancy, go for a surgery. So this slide is important. Follow it closely, and then you can correctly reach all thyroid nodules. Now, what are the prognostic indicators? So we have certain scores like the ages score and the masses score. Ages score and masses score has few things in common. They take into consideration age, histological grade, extrathyroid invasion, and metastasis. Then similarly for the masses score, it is METS, that is again the distant metastasis, age, completeness of the original surgical resection, this is done post-operatively, and extrathyroidal invasion and the size of the original lesion. So these are the scoring methods where you can judge the size of the mass, like the thyroid mass or the adenoma, whether it is malignant or whether it is benign. And if it is malignant, then what are the prognostic indicators post-operatively and pre-operatively. So these are certain scoring methods. Then once you have the tissue in hand, Then you have the TNM scoring or TNM staging, that is a tumor. So depending upon that level, like this is all age dependent also. So if we are looking into the younger population, that at any T, any N, but there are still no METs, then you label it as stage 1. And for any METs, it is stage 2. So once the metastasis has taken place, you are already on stage 2 of the malignancy for the younger population. But if you look at the older population, stage 1 is correlating to any T1. That is, T1 is limited to thyroid, but 1 centimeter or less. No nodal involvement, no METs. T2, stage 2 is involving T2 and T3, but still no nodal involvement, no METs. Stage 3 is T4, or we have at least 1 nodal involvement. So moment the lymph nodes are involved, it becomes stage 3 in the older population. Stage 4 is any T, any N, but it is METs. So metastasis is the deciding criteria of the severity finally. Lymph node involvement is another important criteria. Otherwise, till the mass is confined within the thyroid gland itself, we talk of stage 2. Okay. So that is about the TNM staging. Now, what about the low risk groups and the high risk groups? How do we say that this patient falls under the low risk group and the high risk group? So usually the younger population, that is men of 40 and women of 50, coming to you without this metastasis puts them at high risk. So age itself is a low risk group. If the patient is having no meds and the age is a little more, so all older patients, but the mass is confined within the gland. So intrathyroidal papillary carcinoma or follicular carcinoma with minor capsular involvement and the size is less than 5 with no meds. Meds should not be there. So that becomes a low risk group. If it is a high risk group, that means first of all, senior people, that is older age population, or younger population with meds. All older population with extrathyroidal papillary care. Here it was confined to the thyroid. So it is the moment it is extrathyroidal, metastasis, distant involvement, or older population involved, then they become a high risk group. So is that clear? So we are very sure about what are we talking. Why this is important? Because we'll be coming to the management part. So we know how to follow them up for life. Management part, most important is surgery. So we go for surgery, the treatment of choice, go for thyroidectomy. Now, how much thyroid is to be removed? That is controversial. That is very subjective. Though nowadays we are all prescribing and suggesting a total thyroidectomy, extensive with all nodal resection also. But there are another school of thought. There is a conservative school of thought, and we'll see how they defend their case. After surgery, medical management, it has to be followed by radioactive iodine ablation. It can be covered with chemotherapy. Post-operatively, thyroid hormone has to be replaced for life, and we need to keep the TSH suppressed. So that is again a controversial topic. TSH suppressed, how much, till when? The thyroid surgeries are more commonly related to how do we manage the lobe which is still healthy. So the management of contralateral lobe. Either we go for ipsilateral lobectomy. So we go for one lobe is removed, or we go for subtotal thyroidectomy. It is near total thyroidectomy or the total thyroidectomy. So this is the preferred types nowadays. The total thyroidectomy. Now, people who defend the extensive surgery say that the survival is better with near total or complete resection. The recurrence rate is very less, and there is no other lobe to prevent the recurrence. So we don't need to bother about recurrence. We are trying to decrease the metastasis also, because once the tumor is out, the mets are also not possible. So we are trying to reduce the number of mets also. And another clue is that even if you're operating half lobe or full lobe, the surgical mortality and surgical morbidity is just the same. Improved sensitivity of the thyroid, serum thyroglobulin. Thyroglobulin becomes an important marker that we studied. It becomes an important marker post-operatively. So we follow up with the thyroglobulin. If it is again rising or it is normal. Radioiodine is used post-operatively for a complete cure. And it also reduces the possibility of residual tumor. So there is no gland remaining. So there is no chance of residual tumor, which might later on become anaplastic carcinoma. So that is the argument in favor of total thyroidectomy. And the studies have also shown that the patients who had gone near total thyroidectomy, the survival rate was more, the death rate was less, whereas the death rate was higher in the group which was given less than the near total thyroidectomy. This study has shown us that it is complete thyroidectomy which is more important. But then there is another school of thought which says no, we should go for less radical resection, because they say that the complications are higher for total thyroidectomy, and if you keep some thyroid tissue, preserve some thyroid tissue, then the side effects are less, mortality is less, and the recurrence rate anyways remains the same. So that is the argument given in favor of less radical resection. Now coming to the variant types of carcinomas individually. Papillary carcinoma. Papillary carcinoma, as we talk, is the most common thyroid malignancy. So it is seen almost 80%, 75% we just studied. And this is the variant which is related to iodine sufficient areas, but when patient is exposed to radiations. Again, females are more affected, that is 2:1 ratio. Age is younger age involvement. Patient is mostly euthyroid in status, and this is the malignancy with best prognosis. It will present to you as a firm nodule. There's a firm solid nodule which on syntoscope scan will come as a cold nodule, and on ultrasound MRI you will find a solid nodule. In MNGs, that is multinodular goiters, you come across a dominant nodule. That dominant nodule, which is a larger nodule, is most likely to get converted or most likely to get diagnosed or present as a papillary thyroid carcinoma. Lymph node mets are common, but may even be the presenting symptoms at site. So you do come across conditions like lateral aberrant thyroid, which is actually the thyroid papillary carcinoma, which is metastasized to the neighboring lymph node. Distant mets is uncommon at the initial presentation, but you can find distant mets in 20% of the cases, and it is mostly the lungs, liver, bones, and brain. So from thyroid, it will reach the nearing organ, the lungs or the liver, bones or brain. So the papillary carcinoma, FNAC is diagnostic. Treatment is, of course, it is thyroidectomy. Most likely we suggest a total thyroidectomy with, as there are no lymph node involvement, so we don't recommend that, but mostly the surgeons nowadays prefer taking out the nearing lymph nodes also. So near total thyroidectomy along with lymph nodes, and prophylactic lymph node dissection though is unnecessary, but sometimes it is done. Coming to the second variant, that is the follicular carcinoma or adenoma. So how do we differentiate? So follicular adenoma is the one when the tumor is still encapsulated. So when the mass is, the capsule is intact, we say that it is just an adenoma. If the capsule has been evaded, there is invasion of the capsule, then we call it a carcinoma. But please remember, the histology or FNAC or the frozen section are not sufficient to tell you whether it is an adenoma or a carcinoma. So most likely, if it is a follicular variant and the size is more than 4 centimeters, we always suggest go for a surgery. So it is lesser in prevalence. It is only 10% of the cases. More common in iodine deficient areas. Again, women are more affected. This is a carcinoma which will present later age, that is after 50. Solitary thyroid nodule, which is rapidly increasing in size. And there is a long-standing goiter with cervical lymphadenopathy, which is uncommon at presentation, but distant mets may be present. Very rarely it can be a hyperfunctioning nodule also. FNAC cannot differentiate between the benign and malignant. So pre-op diagnosis is difficult. If it is more than 4 centimeters, go for a surgery. So go for a surgery means go for a lobectomy or a total thyroidectomy. Prophylactic nodal dissection is again unnecessary, but mostly the surgeons do it as a preventive measure. Comparing papillary and follicular, you will find that the follicular is more, the prevalence wise, you will find that papillary is the most common, and also you will find that papillary has the best prognosis. But in males, the incidence is more of the follicular variant. Lymph node mets are more with papillary. Blood vessel invasion is, follicular is more invasive. Recurrence rate is again high with follicular. Mortality is also high with follicular. Distant mets are higher with follicular, though nodal involvement and local recurrence is more common with papillary. So overall, it is the follicular variant which is more serious. Post-operative management, once the surgeon has done his job, the patient will come back to you. As I told you, physicians are the beginning point, physicians are the end point. So one important thing that you will have in your hand is to replace thyroxine. Thyroxine replacement is important because now the thyroid is not functioning and thyroxine replacement has to be done. And once you decide to replace thyroxine, keep your TSH under 0.1. So we have two groups. Why did we study the groups, the low risk and high risk? Because we need to know where do we keep the TSH. So in the low risk group, you keep it between 0.1 and 0.4. In the high risk group, try to keep your TSH below 0.1. Thyroglobulin measurement is recommended once in 6 months, and that is, it should be below 2 nanogram per ml or less than 5 nanogram per ml in hypothyroid patients. If it is more than 2 nanogram or if it is rising, then that is suggestive of the persistent tissue, thyroid tissue still there, and the recurrence is likely. Post-op management, after surgery, you can also go for radiotherapy, though it is controversial. Some decide it, some go for it, some don't go for it. You can go for some studies. They have shown some small improvement after the surgery if a RAI is given. RAI, though it is less sensitive than thyroglobulin in detecting the metastatic diseases, iodine 131 detects and treats 75% of the mets. Now, these are studies which have shown that when alone surgery was done and surgery followed with thyroxine alone, or a surgery followed with thyroxine plus radioablation, the survival rate was maximum when surgery followed by radioablation and then followed by thyroxine suppression was followed. So this is one trial which is shown that after surgery, go for a radioiodine ablation, and after radioiodine ablation, replace thyroxine. And once you replace thyroxine, keep it below 0.1 for the high risk group. Now, percentage of data which has shown the distant recurrence, again, the distant metastasis rate was lower with in the group which was given thyroxine plus radioablation after surgery. These are the commonest variants. Now the very rare variants, that is the Hurthal cell variant. Hurthal cell carcinomas or Hurthal cell variants, they are the enlarged epithelial cells with abundant eosinophilic granular cytoplasm as a result of high number of mitochondria. Hurthal cells are hypothesized to be of the follicular origin. Hurthal cell adenoma is rare and have the potential to become malignant. Compared with other thyroid carcinomas, they have a lower avidity for iodine 131. So they are a variant of the follicular carcinomas. Medullary thyroid carcinomas, you will find that very rarely they are the parafollicular variants, as we know. 5% of the thyroid malignancies are of the medullary thyroid carcinomas. They are arising from the C cells or the parafollicular cells. Again, women are more commonly affected, 1.5:1. Presenting age will be 50 to 60 years. They will present with a neck mass with lymphadenopathy, and there is some local pain or aching. Now, how do they actually present? They can be sporadic, but most commonly they can be familial also. And if they are familial, they have a better prognosis. Then it is MEN2A, that is a Sept syndrome, where we talk of the thyroids, parathyroids, and the FAO. So thyroid involvement is in the terms of medullary thyroid carcinoma, parathyroid hyperplasia because there is hypercalcemia. There will be parathyroid adenomas also, and then there will be FAO. If this is the situation, please treat FAO first. So let us solve out the FAO first, and after FAO we talk of either the thyroids, and in the same sitting we can also sort out the parathyroids. Then the MEN2B or the Wermer syndrome. Here it is just the thyroid, parathyroid, and FAO, the same. But besides this, there is also mucosal involvement. There are mucosal neuromas and the marfanoid habitus. The physical appearance will be tall, thin, marfanoid picture, like the Marfan syndrome. And there are also multiple mucosal neuromas are there. Now the medullary thyroid carcinoma. Sept syndrome, that is MTC. PHEO and parathyroids. Autosomal dominant. I just had a family where the mother was diagnosed first with MEN2A, and then the son, she had two sons. So one also had MTC along with PHEO, and the second son, the red oncogene also came positive, though he had no symptoms so far. So we suggested a thyroid resection for both the sons also. Though there was no feature of MTC, it was only the mother had a full-blown picture of PHEO, parathyroid hypercalcemia, parathyroid adenoma, and the MTC. The sons, one of the son had a PHEO, but no other feature, and the second son had nothing at all, in fact. But all the three came out to be ret oncogene positive. So it's an autosomal dominant condition, and the mean age of presentation is 27 in MEN2A. 100% develop MTC. So that was the reason that though we did not have the picture of MTC, but because the ret was positive, the ret oncogene was positive, we subjected both the sons to thyroid, total thyroidectomy. And the survival rate is good if the surgery is done in time. On lab workup, you require to do a serum calcitonin levels, serum calcium levels, because we are looking for parathyroid adenomas, medullary thyroid carcinomas, and also PHEO. So you need to have your 24-hour urinary catecholamines, that is metanephrines, and the VMA normetanephrines. You can go for FNAC, genetic sampling of all the first degree relatives for the ret proto-oncogene. So this is what we did. Then the medullary carcinoma, MTC basically secretes a lot of other compounds. So calcitonin is just one of them. It can also secrete CEA, carcinoembryogenic antigens. Then CGRP, PGA2 and F2 alpha, serotonin also. It may develop flushing and diarrhea because of the serotonin. Cushing syndrome can be there. Diagnosis is easy by the history taking and the physical examination. Lab workup giving you a raised serum calcitonin and CEA. FNAC will be give you the histological picture. Screening is done with red point mutation, the red oncogene studies. There can be coexisting PHEO, so you rule out the 24-hour urinary levels of the urinary catecholamines. Then there can be hyperpara because of parathyroid adenoma, and that will present as hypercalcemia. So some of the syndromes, if you revise, it is MEN2A, which is MTC, PHEO, and the parathyroid adenoma, along with lichen planus and amyloidosis. MEN2B, which is the Wermer's, which will give you MTC, PHEO with marfanoid habitus, and the neuromas and gangliomas. Familial MTC will give you medullary thyroid carcinomas. There's a series of it. Then MEN2A and Hirschsprung's, MTC, PHEO, and primary hyperpara along with Hirschsprung's. So these are some of the syndromic pictures of the medullary thyroid carcinomas or the thyroid malignancies of the parafollicular variants. How do we treat them? Mostly, more than 50% you will find that it is multicentric or they are bilateral. So we go for total thyroidectomy. Along with total thyroidectomy, we also do a bilateral central node dissection as a routine. Bilateral modified radical.
नमन खोल पापा है क्या? खोल बेटा.
We have a palpable lymph nodes. Ipsilateral prophylactical nodal dissection can be done in tumor size more than 1.5 centimeters. External beam radiation is required for unresectable residual or recurrent tumors. Then chemo has no role. So it is the surgery which is important, and after surgery you can go for an RT, that is radiotherapy. Now the medullary carcinoma, prophylactic thyroidectomy in RET mutation is detected. So we go for RET studies in all first degree relatives, and if you find RET positive before 6 years of age for MEN2A, you go for thyroidectomy. Though what the case I am discussing, to me the mother came was around 55, 60, and both the sons were in their 25s and 30s. So it was quite late though, but there was no feature of MTC still. So we did a total thyroidectomy. But what the recommendations are that in case of MEN2A, go for a total thyroidectomy before the age of 6 years, and for MEN2B, even do it before 1 year. So if the RET oncogene is, RET mutation is positive. Anaplastic carcinomas, they are very rare. Again, women are affected, but they are the most dangerous types. The mortality is very high, mostly presenting in the later ages of life. There's a long-standing neck mass which is rapidly enlarging. They can be painful with dysphonias, dyspneas, and dysphagias. Lymph nodes are usually involved at presentations, and their distant metastasis may or may not be present. Prognostically, we all know, we have studied papillary carcinomas are the best, follicular carcinomas follow them. Hurthle cells are also having a mortality of 20% mortality rate at 10 years. Medullary carcinomas and anaplastic medullary carcinomas, the survival rate is good, but anaplastic tumors have the least survival rate and they are the most dangerous type. And the median survival of only few months after the diagnosis. How do we manage? Though we have all discussed the management, but just a generalization that total thyroidectomy with lymph node dissection if required. If the patient has MEN syndrome, then just remove FAO first. Post-op serial calcitonin and CEA measurements are done. In papillary and follicular carcinomas, again, total thyroidectomy with lymph node dissection, post-op radioactive iodine ablation, long-term TSH suppression, that is thyroxine therapy, follow up with your thyroglobulin levels. You can go with imaging studies. Radioactive iodine whole body scan may be done if needed. But whenever you're going for a radioactive iodine studies, you have to allow the TSH to rise so that we can find out the mets in other parts of the body. Neck ultrasound, CT scan or PET scan can be done. Whenever you are preparing for the scan, avoid thyroxine for some time. Allow the TSH to rise around 25, up to 25. Then the thyroglobulin presence will always tell you whether there is a recurrence. So presence of thyroglobulin and the iodine scan will tell you whether there is still residual thyroid tissue, and that residual thyroid tissue is a likelihood of recurrence. Nowadays, we also have the recombinant human TSH, that is thyrogen, which can be used for a thyroscan rather than going for a thyroxine withdrawal. Though we don't have this here in Jaipur. I'm not sure of any other place also. We are just following up till this stages that we go for iodine scan. TSH suppression therapy, again, as we have started, we go for a TSH suppression therapy pretty long, depending upon the low risk groups and the high risk groups. So this is how we do it. If it is a TSH, we keep below 0.1, low to undetectable. That is if there is persistent or recurrent disease in the high risk groups. If it is no evidence of distant disease, so there's a low risk group, we go for 0.1 to 0.4. But if it is very low risk group with long-term survivors, then we can keep it in the normal range also, that's 0.5 to 1. These are the targets of TSH suppression therapy or the thyroxine therapy. This is about the thyroid malignancies that we need to know as physicians. I can take up the questions if you have any. So there's one question from Dr. Neetu. So Dr. Neetu, I think now as after the last slide, you must have got the answer to your question that depending upon the risk group of the patients, we try to keep the TSH in the suppressed range and we probably keep it below 0.1. So that is a target, and not allowing the patient to go into a stage of hyperthyroidism, that is iatrogenic hyper is something we don't want, but still we try to keep it suppressed. Yeah, we will be sent the most of the recordings are already available, and Mr. Ajay is here. He's taking help and he's helping us to put all the slides on the YouTube also, and the recordings will also come to you. So not to worry about that part at all. So do we have any more questions now? So that was the last class for thyroid malignancies and thyroid modules. We have completed the thyroid modules, and probably we have also already announced the EndoPearl session. Yes, we are avoiding semaglutide in medullary thyroid carcinomas because we have the GLP-1 receptors there, sir. So we have the GLP-1 receptors in the parafollicular cells, and we are avoiding most all the GLP-1s in the cases of medullary carcinomas, MTC, the history of MTC, because it was found in the during the evolution of the molecule, it was found that they were increasing the incidence of MTC. Though it has not been proven, In human studies, it has not been proven, but in the animal studies, it was there. So we are avoiding this molecule in the cases, proven cases of MTC. So thank you so much. As I was telling you, we have already announced the EndoPearl sessions, and you can start if you are interested to continue with these EndoPearl classes. You can post a mail to me or Dr. Keswani, anybody. It is already there on the website, and if you want, I will post the same to on the group also. And this group is there. This group is not going anywhere. If we want to continue any discussions about anything in endocrinology, we can definitely discuss here. Thank you so much for being here, and it was really nice being with you all here.